Ladies and gentlemen, thank you for your patience in holding. We now have your presenters in conference. Please be aware that each of your lines is in a listen-only mode. At any time throughout today's presentation, you may submit your questions electronically by using the discussion area located on the left of your webinar. At the conclusion of today's presentation, we will also open the phones for audio questions. At that time, instructions will be given as to the procedure to follow if you'd like to ask an audio question. It is now my pleasure to introduce today's first presenter, Mr. David Baker.
Good afternoon, everybody, and welcome to our ongoing webinar series brought to you by the National Implementation of TeamSTEPPS. Today's topic is on improving safety for patients with limited English proficiency. This is actually an overview of another resource through the TeamSTEPPS now growing suite of resources. Whoops. Of course, there was some user error. Anyway, just to get back to this, some acknowledgements. And starting out, first of all, we, as always at the beginning of these webinars, want to thank our sponsors, those being Jim Battles from the Agency for Healthcare Research of Quality and Ms. Heidi King from the Department of Defense. Both have been critical to the development, launching, and deployment of the TeamSTEPPS curriculum and the tool we're going to hear about today. I also want to acknowledge our project team. This project is actually led by the Health Research and Education Trust. They are Barb Edson, who is the project director, and Chris Hund, who usually hosts this particular event. Unfortunately had a conflict today, but we wanted to keep the series ongoing. And I am David Baker. I am from Impact International, and as you can see, I am learning how to advance the slides, but I will try to do better this time. Just to remind you, as you know, we run collectively AHRQ, AHRQ, DoD, and Impact, the National Implementation of TeamSTEPPS program. This program brings you opportunities to participate at any one of 5, now 6 centers in the training to become a master trainer. The master trainer training course is a 2-day training course. It's held at local institutions where you receive training from qualified experts who are also deploying TeamSTEPPS in their hospital. This is a highly coveted training. We will be continuing the program over the next series of months, and if you want to find out more information, you should certainly contact the Health Research and Education Trust. So here is a direct number to find out about enrollment, as well as an email, either to learn about how to get involved in TeamSTEPPS through the training, or support that you might need for your implementation now that you've completed training or you're in another phase of your program as you participate in the journey of trying to improve patient safety and quality. As the moderator mentioned, David, already, some rules of engagement for today. First of all, we would like to do this as much as possible through written questions. We have operators, so to speak, available on the written end that will answer your questions in real time, should they be able to. Other questions for our session presenter today will be held to the end, and I will then talk to our speaker and ask her the questions, and if there is still time at the end, we'll open up the lines for your own individual questions directly. Today's presenter on this particular module that we are block of TeamSTEPPS tools that we often refer to as the LEP curriculum is Laura Maynard. I've known Laura for a number of years. She actually was part of one of our regional training centers and helped with the original launch and roll-up of the national implementation of TeamSTEPPS. Currently, she's the Director of Collaborative Learning at the North Carolina Center for Quality and Patient Safety. She's a qualified TeamSTEPPS Master Trainer. She was involved in the development of the Limited English Proficiency module, and she has taught TeamSTEPPS to hundreds and hundreds of people, as well as implemented it within various hospital systems. In terms of some of the specific webinars objectives today, like I said, Laura's going to go over this new tool and resource that AHRQ has made available for you. She's She's going to highlight some of the background and what we know about patient safety in LEP patients. She's going to identify some of the common causes for adverse events related to LEP and culturally diverse patients, present some strategies for improving detection of medical errors and preventing high-risk scenarios from becoming safety events, and provide an approach to preventing safety through the use of TeamSTEPPS tools, or preventing safety events through the use of TeamSTEPPS tools. With that, I would like to turn the floor over to Laura Maynard. Laura, the floor is yours.
Thank you, David, and thank you, everyone, for participating in this session today. I'd like to start with the patient and with the patient's story. This is the story of Willie Ramirez, and it illustrates why patients with limited English proficiency are at a risk of patient safety adverse events. This case is one of the most well-known examples in which limited English proficiency and cultural misunderstandings led to a truly tragic medical error. Back in 1980, 18-year-old athlete Willie Ramirez was taken to the emergency department by ambulance. He was in a coma. He was accompanied by his mother, his sister, his girlfriend, and his girlfriend's mother. The emergency room physician, who did not speak Spanish, assumed that Willie had a drug overdose because he had pinpoint pupils and because the girlfriend's mom said in broken English, he es intoxicado. In Cuban Spanish, intoxicado means poisoned. The family thought Willie had eaten a bad hamburger at a new fast food restaurant that same day. When the emergency room doctor told the family that he was going to treat Willie for a drug overdose, they said to one another in Spanish, "That's impossible. Willie would never take drugs." Willie was an all-star baseball player. He was opposed to drugs and drinking and very outspoken about that. But the doctor did not understand what the family was talking about among themselves. Willie's brain hemorrhage kept bleeding for more than 2 days before a neurologic consult was scheduled, and by then, Willie was quadriplegic. The family sued the hospital, resulting in a $71 million settlement. Although the emergency room physician did not understand what was said at the time, in a later interview, he said, "If I had a mom in that ER who was saying my son would never use drugs, I might have thought about it differently." However, the family member who was interpreting did not share that information. Sometimes, culturally, it's difficult to speak up and contradict an authority figure like a doctor. So in this case, neither the doctor nor the family asked for a professional medical interpreter because they all thought they were communicating. A professional interpreter could have facilitated better understanding in this case by interpreting the doctor's and the family's words to one another, all those words, and by asking questions and making sure that they understood correctly, and perhaps by speaking up when the family expressed doubts about the doctor's diagnosis. We would like to think that this was a long time ago, 1980, that's ages ago, and that this couldn't happen now. But I recently spoke about this topic to the Texas Association of Healthcare Interpreters and Translators, and they assured me that although without always such severe consequences, these misunderstandings do happen, and they happen often. If you want more of the full story about Willie Ramirez, the link is at the bottom of that slide if you want to get the detail on it. Oops, I did the same thing, David. I hope you feel better now. All right, this information is found in the Guide for Hospitals that accompanies the Limited English Proficiency module of TeamSTEPPS. And the citation is there and the location where you can find this guide for hospitals. This guide was developed by the team at Massachusetts General Hospital in collaboration with others who worked on developing this TeamSTEPPS module. And it provides a lot of background about the safety issues and risks for folks with limited English proficiency and ways that hospitals and hospital systems can address those risks and can minimize those risks. From a history of focusing on patient safety, we know that patient safety efforts are now a central component of strategies to improve quality of care for all patients. So any effort that you have in a hospital setting to improve quality of care is going to include patient safety. There are significant issues for patients that have limited English proficiency. The research demonstrates that language barriers can have a strong impact on many aspects of healthcare and can contribute to disparities in safety between English-speaking and limited English proficient patients. Communication problems, as you probably know, are the most frequent root cause of all serious patient safety events that are reported to the Joint Commission. But you see from this chart that harm experienced and the severity of that harm is consistently greater for those with limited English proficiency. The risks are greater, the harm is greater. It happens more often, and when it does happen, that harm is more severe for those who don't speak English well. So why focus on this? Clearly, it's a significant problem. Minority groups are the United States' fastest growing demographic, accounting for 1/3 of the United States population. Nearly 25 million people in the U.S., about 8.6% of people, are defined as having limited English proficiency. And therefore, they're at risk for adverse events because of language barriers and because of cultural barriers. This is a lot of people. It's a huge impact. There's a greater risk for patients with limited English proficiency, and they tend to have longer hospital stays compared to their English-speaking counterparts. So an English-speaking patient with the same clinical condition will have a shorter length of stay in general than one with limited English proficiency. There's also a greater risk of surgical delays and a far greater risk of readmissions. This is a problem that ties very directly to readmissions to the hospital because patients with limited English proficiency have a greater difficulty in understanding instructions, maybe preparation for a procedure or how to manage their condition, how to take their medications. All of those issues that are where the communication piece is so vital and where we can easily have a gap in communication, that gap is intensified for patients who have limited English proficiency. It's a risk management issue. Multiple liability exposures arise when you're providing care to populations with limited English proficiency, and you can see there can be problems with their comprehension of their medical condition. There can be all manner of consent and informed consent problems, complications. Many risk management issues arise. In 2011, the Joint Commission published patient-centered communication standards in the Comprehensive Accreditation Manual for Hospitals, and these standards emphasize effective communication and cultural competence and patient-centered care. So these pieces are crucial to your accreditation as a hospital, and they are crucial for patients with limited English proficiency. The causes of adverse events for patients with limited English proficiency and culturally diverse patients, some of them are very similar to the causes of adverse events for English-speaking patients, but some of them are a bit different. One of the key problems that we see is the use of family members or friends or non-qualified hospital staff as interpreters. Family members and friends typically do not understand the subtle nuances of language and culture that might influence a medical interaction. And even more strongly, they likely will not question the use of medical terminology. Research confirms that bilingual hospital staff often serve as ad hoc interpreters for patients with limited English proficiency, despite evidence that they're more likely to make clinically significant mistakes than qualified medical interpreters. So using hospital staff who can somewhat speak that other language is not a safe way to care for your patients who have limited English proficiency. Clinicians with basic or intermediate foreign language skills very often attempt to make do or to get by without the use of a trained and competent interpreter, and this increases patient risk. Further, cultural beliefs and traditions impact patient care. Sometimes it's a cultural belief to minimize reports of pain or to defer to authority figures. Gender roles can come into play. And all of this can influence the medical encounter and can compound the risk for patients with limited English proficiency. Hospitals can engage in a systematic approach that will better identify and better prevent these common medical errors and adverse events in this population of patients. The hospital guide that I mentioned and that we showed the link for presents 5 key recommendations that represent sort of the ideal system. But they can be implemented in different phases depending on where your hospital is, what your structure is currently, where your strengths and weaknesses are. Essentially, you need to foster a supportive culture for the safety of diverse patient populations. You want to adapt your current systems to better identify medical errors among limited English proficient patients. You want to routinely monitor patient safety for this group, and then to address the root causes that will prevent these medical errors. And this is just a chart that shows those 5 key elements in general and how they interact with one another. You can see that fostering a supportive culture for a safety of diverse patient populations is kind of the overarching piece. Both identifying and reporting risk and events in that population fit into the picture. You monitor all of that and then address and prevent what you're finding. And we're going to talk about each one of these 5 elements individually. So culture. That's the first of the key systems. This culture should be articulated clearly by your hospital leadership. It needs to be operationalized in your strategic planning for your organization. It needs to be supported by providing staff with key tools and resources to accomplish this supportive culture for the safety of diverse patient populations. You want to link the goal of overcoming language and cultural barriers to the overall message and mission of a culture of safety. This is a key component of patient-centered care. Patient-centered care must be culturally sensitive and must include appropriate language services. You can frame this cultural goal within your existing operational policies and standards and share lessons learned from the events that do happen or the risks that come up. And also very key is to involve patients in your patient family advisory councils or cultural advisory groups to incorporate their perspective into hospital leadership and planning and decision making. It's key to have patient and family advisory councils in your hospital, and many are moving toward that. As you do that, consider that you want the diversity of that council to reflect the diversity of your patient population in terms of culture, in terms of ethnicity, and in terms of language. The second key structure is to better identify medical errors among patients with limited English proficiency. You have to adapt to your systems that you already have in place to better identify medical errors and to improve the capacity of patient safety systems to capture root causes and risk factors, and then to link the databases to make that information readily accessible. One of the key problems that was found in the research leading to this module is that data on race, ethnicity, and patient language and interpreter needs is not always included in the electronic medical record. If it's not there in the record, it makes it very difficult to ensure that the patients consistently get the services that they need, but it also makes it very difficult to track the need and to report out and to have those data fields in your safety systems so that you can understand the role of language and culture in patient safety events that are reported. Reporting is the next key element. You want to develop strategies to empower frontline staff and interpreters to report medical errors and to provide them with the training and systems to do so effectively and efficiently. When I spoke with the Texas Association of Healthcare Interpreters and Translators group, I asked them about how often they report events or near misses. When they're working in the hospitals, how often do they report an event or near miss? 0. Never. Not one person in that whole room admitted to ever reporting an event or a near miss. Then I asked them, how often do you see adverse events and near misses? Lots of nodding, a little bit of raised hands. Very often that folks in the interpreter role see the risk, see the error, but they don't feel empowered to report it. They may not even know what the patient safety reporting system is in that hospital. As a part of your training for interpreters, as a part of their role in your organization, they need to be a part of reporting. You also need to consider other ways of identifying errors outside of your standard safety reporting system. What are other ways to gather those risks and keep track of them? Another needed system is to routinely monitor patient safety for limited English proficiency patients. You want to develop systems that do this regularly, as well as processes that will analyze any errors that happen, any near misses that happen among this population. So that means you look at your safety reports and dashboards in a way that can divide out the population of folks that have limited English proficiency so that you can see how you're addressing their specific and enhanced risks. We've already shown from the evidence that they have a greater risk of having an adverse event. So how are we addressing that greater risk? If you're not regularly monitoring your safety system for that population, it will be very difficult to develop strategies for improvement and for error prevention. And then finally, we want to address the causes of those medical errors among this population of patients. Develop strategies and systems to prevent error by strengthening your interpreter services. You need dedicated services for medical interpretation. We need to figure out how to strengthen that. Improving coordination between the interpreters and the clinical services. Providing translated materials and developing training for healthcare providers and for staff on use of interpreters, on cultural competency, and on advocacy for patients. One tool in this arsenal of being able to address these root causes, and a powerful tool, is the TeamSTEPPS module for Limited English Proficiency. You want to be able to train folks in a way that can get your interpreter services, your staff, your physicians, your leaders together and have that multidisciplinary team training on communication with a focus on patients that have limited English proficiency. You also want to look at your systems for how are you going to schedule an interpreter at the critical clinical points of service. How do we make sure that we have an interpreter available at the times when they're most needed and when risk to the patient is greatest? And if we're going to be relying on our bilingual staff as a form of language assistance, then we need to ensure that they get training in basic medical interpretation. Simply being fluent in another language isn't enough. They need that certification. So several of the activities that we've talked about as being things that are needed to enhance the safety for your patients with limited English proficiency are included in the TeamSTEPPS module. Most of you are familiar with TeamSTEPPS. It's an evidence-based teamwork system that's aimed at optimizing patient outcomes through improving communication and other teamwork skills. The 4 key skill sets are in the middle of that triangle. You'll see leadership, situation monitoring, mutual support, and communication. Those are 4 key sets of skills, the core skills that the entire care team needs to be able to use in order to keep all patients safer. That entire care team is the circle that's around those 4 components, and that team includes the patient, their family, and the medical interpreter. So making sure that you have the whole team on hand utilizing those 4 skill sets will enhance your performance. The TeamSTEPPS module in enhancing safety for patients with limited English proficiency can be found at this link. It's available there. And it trains this interprofessional care team that works together in hospital units, giving them the knowledge, the attitudes, and the behaviors needed to reduce the number and severity of patient safety events. The module is free, it's publicly accessible, it's customizable, and it contains a training module, video vignettes, workshop materials, a training guide, an evaluation guide, a metrics guide. It's a huge wealth of resources that's all right there at this website free. All you have to do is go and download it and use it and customize it to your setting. This module focuses on these high-risk settings and situations. As we mentioned earlier, the research shows that patient safety events that affect patients with limited English proficiency tend to be more severe and are more frequently due to communication errors compared to English-speaking patients. Patients in this population are particularly vulnerable when they're interacting with staff in the emergency department, in obstetrics and gynecology, or in surgical settings. When care is time-sensitive and communication with the patient and their family is crucial, intake, transitions in care, discharge, medication reconciliation, these are the points at which patients with limited English proficiency may need additional supports. We've mentioned many times that the research shows that without a professional interpreter, interpretation errors are more common and much more likely to have potential clinical consequences. When the care team asks family members or housekeeping staff to interpret, or when they rely on their own limited language skills or the patient's limited English, they're placing these patients at risk for physical harm. In addition, you're placing the ad hoc interpreter at risk for psychological harm. It would be horrible if you were the family member of someone and you were trying to interpret and get by with your language skills and there was an adverse event. It would be equally horrible if you were staff, nursing staff, auxiliary staff, trying to interpret and trying to help and something was missed in a way that caused harm. That's damaging to the people involved. Another risky situation is when the interpreter arrives after the encounter has begun or is called away before the encounter ends. Ideally, the interpreter should be present for the whole encounter. And if this is not possible, then the interpreter needs to be briefed when he or she arrives, and a backup plan should be in place if the interpreter has to leave. And here's just an example. Whenever we were doing the preliminary research that went into this training module, 18 people were interviewed in 3 different hospitals, all the frontline staff and leadership. So this was folks in nursing, in patient safety, and in interpreter services. And all 18 reported situations where an interpreter was needed but was not present. In several cases, this led to close calls like the ones that I'm going to describe in this story. But of the 18 people interviewed, 100% of them knew of an example where an interpreter was really needed and wasn't present, and that led to risk to that patient. In this particular example, the interpreter said, well, the patient came in for the surgery, and it was assumed that she spoke English, and after the whole assignment and assessment was done, the patient answered a question inappropriately, and that made the nurse doubt. So the nurse called the interpreters, and I arrived, and the nurse said, this patient said she's not allergic to any medicine, drug, or latex. And when I interpreted, the patient said, I'm allergic to latex. And the nurse kept saying, are you sure? And she said, yeah. The nurse said, what happens to you? Well, they put the latex band on, and it was itchy, and it was red, and it was swollen. So the nurse had to stop, run, call the operating room, put the latex sensitivity on, move everything out of the OR. A near miss. It was almost missed before surgery. This type of miscommunication happens frequently. There is within the module some wonderful videos. We're not going to show them today, but there is a video of a case study that highlights a situation that could have occurred in any hospital anywhere. And it focuses on all the processes of care. There's, of course, as in most TeamSTEPPS modules, we have the opportunity video where not all of the skills are used, and you can see the results of that. And then there's the full-length success video that shows the use of the TeamSTEPPS skills and how that makes a difference in the outcome. There are also the short video clips that illustrate the specific skills that are taught within the module. We talk in the module about the benefits of including the interpreter fully on the care team. This has significant benefits to the patient, but it also has great benefits for the team. It ensures that both the patient and the care team have accurate, complete information, and that facilitates good decision-making. The interpreter achieves this mainly by interpreting the spoken words or written documents. But in addition, the interpreter can serve as an advocate, speaking up when he or she thinks the patient or provider might have missed something. The interpreter can be sort of a cultural broker, helping healthcare providers understand cultural perceptions and expectations, and helping the patient understand the expectations and the culture of healthcare. So that cultural broker role begins to go beyond just translate the words, just interpret the words. And some time back in some healthcare settings, there was sort of a black box model of interpreting, where interpreters were to limit themselves to just the words, no opinion, no interpretation, and no cultural advocacy. Now we're moving away from that, and now we begin to think that the interpreter can be that cultural broker that can help the patient better understand and can help the medical staff better understand. It might be useful as you go forward to assess what's the culture of interpretation at your hospital. What's the expectation of the interpreter, and how do we clearly communicate that expectation to them? One element of the module includes this assessment of your particular clinical area on just those issues. And a worksheet is provided, it looks rather like this, to prompt teams to consider what's the process for obtaining an interpreter in your clinical area. The basic key steps include identifying the need for language or cultural support, contacting the interpreter, ensuring that the interpreter remains present through the whole patient encounter, and ensuring that the interpreter is fully informed and integrated into the care team. Now, there are often barriers that make it tough for people to fully implement this whole process. For example, an interpreter is not always available right away, or the interpreter might arrive late or need to leave early. Since these types of problems put patients at risk, it's important that you and your team look at those issues and really talk about it with your patient safety leaders and with your interpreter services leaders. The module has an accompanying guide to help you do that. In the meantime, while you're looking at those high-level issues, your process needs a backup plan. You need a contingency plan for what to do if you can't do this in the appropriate way. If you can't reach the interpreter, what do you do? If the face-to-face interpreter must leave early, can you rely on phone interpretation, or what's the backup plan? So developing those contingency plans is a key part of implementation in this module. One of the skill sets that's taught in the module is assertion, advocacy, and conflict resolution. And this is an example of one of the scenarios that's provided for that. In this scenario, Mrs. Gilbert, a Haitian immigrant, is in the emergency department in triage, and the front desk staff calls the Creole interpreter, Ms. Pierre-Louis. Dr. Malbec is interviewing Ms. Gilbert in French, and she doesn't understand his French. Ms. Pierre-Louis knows that Ms. Gilbert does not understand, but when she attempts to interpret, Dr. Malbec says, "You're not needed, I've got it." So we would then ask, what are the risks to the patient in this scenario? What could possibly go wrong, and what needs to happen to avoid that risk and to avoid those problems? We ask, if you were Ms. Pierre-Louis, what would you do? And have the group discuss that. And some background information that's helpful and that helps focus that this is not just words and language, but culture. There are two main languages spoken in Haiti, Haitian Creole, sometimes called just Creole, and French. Speaking French signals a higher social status, so some patients might be reluctant to admit that they don't understand French well. And most countries will have more than one language and several dialects. It's safest, and it only takes a few seconds to ask patients what language they speak best or in what language they want to receive care, and head off this type of problem that we have in this scenario. That also adds a cultural element to what the interpreter, Ms. Pierre-Louis, would do here. What would you do in that situation when there's that sensitivity that Ms. Gilbert may not want to admit that she doesn't understand the French? How do you approach that with this group? And so you can role play that scenario and talk it through using the skills from the module. Other skills included are more emphasis on advocacy and assertion. And these are useful for any team member who doesn't agree with the decision maker or who notices a patient safety problem, including the interpreter. We talk about when you might use advocacy and assertion to speak up on behalf of patients with limited English proficiency, that you might have opportunities to do that to ensure that patient language needs are truly assessed, or to ensure that an interpreter is called when needed. You may need to speak up and advocate for the patient on that behalf, or to raise communication issues. This is a standard TeamSTEPPS tool. Those of you familiar with TeamSTEPPS know CUS, but structured language can make it easier to speak up and be assertive when it's needed. Using a script of set phrases that the team all agrees on in advance can make interactions more predictable and less personal. In TeamSTEPPS, when we need to stop the line and ensure safety, we cuss. We say, "I'm concerned, I'm uncomfortable, this is a safety issue." And the team understands that when you say that, it means we need to pause and make sure that no safety risks are happening and that the entire team understands the situation. The phrase is a signal, almost like calling a code. It doesn't just mean I'm concerned, although I am, but it also means I see a safety risk, and so I'm saying I am concerned. That's my code language, my phrase for that. And your interpreters can utilize this script, this structured communication, to be able to speak up on behalf of the patient. There are also hand signals or gestures that are useful as code languages for interpreters or patients to indicate a need to stop and listen. For example, raising your hands in front of yourself, palms out, can be an agreed upon gesture to stop the line for interpreters. And there are example video clips of this in the module. When speaking up on behalf of the patient, it's important to voice your concern by advocating and asserting at least twice if they ignore you the first time. Sometimes we call that the two-challenge rule. First two attempts can come from the same person or from different people. You can frame it as a question, an initial concern, but this is how to escalate your assertion, your advocacy for the patient, if need be. The two-challenge tactic ensures that an expressed concern has been heard, understood, and acknowledged. If after two attempts to bring your point forward, you're still being blown off, you still don't feel that it's being acknowledged, then you need to seek assistance from an additional resource, such as the charge nurse, another physician, your supervisor. Take it on up the chain of command if need be, because it's your responsibility to be assertive on behalf of advocating for the patient. Another key skill that's taught in this module is briefing. Once the full team is present and engaged, you need to ensure that everybody's informed, that everybody's on the same page, and this includes the interpreter. Briefs are a communication and team tool for planning purposes. Now, the team leader is responsible for organizing a briefing to kind of get the essential team info out there and to establish an environment where the team, including the interpreter and the patient, are comfortable speaking up and participating. You need to discuss who's on the team, what's your role, including the interpreter. Encourage people to speak up and share any relevant information or concerns, and what are the goals, what's the plan, what's going to be accomplished, who's going to do it, and what are the potential risks. And again, the module has a video that illustrates this. This is about psychological safety, the ways in which we make it safe for people to speak up, because it's definitely one thing to say, we want you to be assertive, we want you to speak up. It's something else for the perceived authority, for the team leader to say, please speak up, I invite you to do that. That creates a safe place for people to be assertive and to speak up and to share their perception of risks. So to create psychological safety, you want to proactively invite input, you want to be accessible and approachable, ask for mutual support, and it's key, the team leader sets the tone for the team. The interpreter sets the tone and creates that psychological safety for the patient. So your team leader might say, feel free to stop us at any time if something's not clear, or if there's anything I should know about the patient's beliefs or culture or concerns. The interpreter might say to the patient, if anything we say is not clear, please let me know. Explicitly giving people permission to speak up is very significant. Another key teamwork tool taught in this module is checkback. Closed-loop communication strategy to verify and validate information exchange. This one's about accuracy. It involves the sender initiating a message, the receiver accepting the message and confirming what was communicated, and the sender verifying that that message was received. So basically, it's just a simple, like a read back, only you're just verbalizing it. It's a check back. They do this well at the coffee shop. When I go order a tall soy double shot mocha, the clerk says tall soy double shot mocha, and the person making the coffee says tall soy double shot mocha, and by golly, that's what I get at the counter, and it's correct, because they've checked it back to make sure they were accurate. It's a very, very simple skill, but crucial for accuracy of communication, and very useful for interpreters to use to ensure that they've understood the communication from the clinical team and the communication from the patient. Teachback is something else, much more than just a checkback. Checkback just verifies accuracy of a fairly simple communication. Teachback is a method that confirms understanding of larger concepts or processes. In a teachback, you ask people to tell you in their own words what they've learned or what they've understood. This technique can be extremely useful for interpreters who can use the teachback to correct any misinformation or missed communications with the patient. Some examples of this would be asking patients to tell you how they're going to take their medication when they get home, or asking them, how will you explain what the doctor has said? How will you explain this to your spouse when they arrive? So tell me in your own words. That's the teachback. And the two resources listed there have just a wealth of information, resources, videos, etc. on how to do a good teachback. So that was a very quick overview of the TeamSTEPPS module on enhancing safety for patients with limited English proficiency. The module itself covers a process for including both in-person and phone interpreters. It has a process for ensuring that you have the interpreter integrated fully into the team. And it focuses on briefing and establishing psychological safety, advocacy and assertion, using the I'm concerned, I'm uncomfortable, this is a safety issue, structured language for speaking up, check back for accuracy, and teach back for a more thorough understanding that the communication was received. So that's a very quick summary overall. There are many references and resources available on this. Just a partial list of the references is there. There are more references listed and more articles to be read if you go to the website link where the TeamSTEPPS LEP module is housed. But at this time, I'd like to be able to open up for questions and conversation.
Laura, this is David. Thank you very much for that presentation. I'm sure everybody on the phone, as well as me, appreciate it. We've been monitoring the message board and doing our best to answer questions in real time. But we do have some time left, and I have a number of questions from the audience for you. Just so everybody knows in the audience, because we have received a number of questions, if we do not get to your question, or there continues to be questions after the fact, as we go through these, we will post answers to the TeamSTEPPS portal for any question that we do not have the opportunity to get Laura to answer in real time. So, Laura, I have a list of 9 so far questions for you. We'll see how you do. Are you ready?
Yes.
Okay, so the first question we have from one of our participants is, how do you suggest recording incidents without creating hostilities between caregivers and interpreters since they work so closely together?
Yes, that's a key issue, and it's important to work that through in conversation. Sometimes this TeamSTEPPS module can be an opportunity for staff in a unit and the interpreters who serve that unit to sit down and talk about just these issues together, to talk about what would it be like if I, as the interpreter, shared a concern that I have about an error that I saw. Where would you want me to take that? How do you want me to report that? So that can happen through conversations that include the interpreter as a part of the team and where that listening and sharing can happen to create a sense where it's safe for all of us to speak up. At the same time, that's a hospital leadership issue. Expectations need to be set about reporting and about safety from the highest levels of the organization, and to be communicated not just in policy, but by those senior leaders in person to frontline staff and interpreters. So the hospital guide that's a part of this module is very helpful for senior leadership in hospitals to look at how do we address our safety reporting system and how do we include our interpreters in that as a way to make our patients safer.
Okay, thank you. The next question is as follows. Is this training at the government link, that being the AHRQ website, what provides the certification needed, or is there other training? How long does the training take?
Okay, we've got 3 different kinds of training that have been referenced, and so I'm going to start, and I think with that question may be a mixing of 2 of them. Training for medical interpreters is separate from the TeamSTEPPS training for enhancing safety for folks with limited English proficiency. And this module of TeamSTEPPS is advocating for the use of trained and certified medical interpreters. There's a specific course that medical staff and physicians can take to become certified in interpreting. It's not the same as a professional medical interpreter, but it's someone who's a bilingual medical professional. They can take some additional training. I'm not sure the length. I think it varies from state to state. And then they're certified as an interpreter. And that's helpful because that gets at those nuances, that gets at some of the issues of interpretation that just because you're a clinician and you speak a second language doesn't necessarily mean you understand everything about interpreting. So that extra course makes it possible for you to use those bilingual staff in that way. So that's separate from the TeamSTEPPS course, which may help you raise up those issues about who needs to take that course and how do we get Dr. So-and-so to stop interpreting because mistakes are happening, and those sort of conversational issues that need to happen within the unit to keep everybody safe. Then there's the full TeamSTEPPS training, which is the two-day course that David was referencing early on in the webinar. And that certifies folks to teach TeamSTEPPS in its entirety, all the modules, to other people within your organization.
Okay, great. So another question here is kind of, and I'm going to broaden it a little bit, but basically what the question reads is, for the slide, close call and interpreter story, would this interpreter scenario also include interpreters for the deaf? And I think more broadly, I think I've seen some traffic about the relevance of this curriculum for interpreters for the deaf.
And while the module doesn't have examples of that type of interpretation, all of the concepts in the module would lend themselves to that very well. You would simply need to customize the examples for your training if you were going to include interpretation for the deaf. And there are prompts and suggestions within the instructor guide for this module that help you do that customization.
Okay. A few more here. Are LEP patients at an increased risk for falls? And is there a fall risk assessment tool that takes being LEP into account?
I have not seen any specific evidence indicating that folks with LEP are at an increased risk for falls. The evidence that's quoted in the module focuses more on all adverse events. It includes falls, but it doesn't just separate out falls. But you might look at that reference list that's on one of the closing slides and that's also included in the module, and there may be something more specific to falls within that. But this considered adverse events overall and the severity of those, the impact of those, and the level of harm. And the adverse events happen more often to folks with limited English proficiency, and the outcomes are more severe. The harm is more severe for them. Okay,
I don't know if we answered this in the prior question because I'm reading questions at the same time you're talking. But just for clarification, could you please define professional interpreter? And there's a kind of a clarification here. Many think it means simply getting someone who is paid to interpret. But is it something more?
It is more. And again, I believe that the regulations on that vary state to state. But there are organizations, associations of professional medical interpreters, and it includes, to get certified as a medical interpreter includes more than just language skills. It also understands a certain level of understanding medical terminology, medical processes. There's more nuance to it than simply translating words. So just because someone's getting paid to translate the words does not mean that they've been trained as a medical interpreter.
Okay. And I'm continuing in order. Thank you very much. There's a question, and I'm going to have to editorialize a little bit on this one. I think it relates to geographic cultural data and where one can find information on national cultural locations and densities. Do you have any information to kind of understand the population you're serving?
Yeah, that's good information. I don't know right off the top of my head where to find it, but again, I would go to that list of resources, and I would start with the studies that were done through Massachusetts General Hospital because I believe they looked at that type of demographic in doing the studies that led to this module. So I would start there, and they likely have that resource. I don't know what it is right off the top of my head.
Okay, we got a couple more minutes, so we have certainly a few more questions. So the courses available for interpreter certification are very much in need of being updated. As you have mentioned, the interpreter has more of a role of cultural broker, yet if you follow the protocol imposed by the courses, then we are at risk of being disciplined. How can we address this matter? I hope that made sense to you, Laura, since you're the expert.
I understand the problem exactly. To rephrase that, particularly in some states, the methodology for training medical interpreters is that black box model of just the words, don't make a judgment, don't make an opinion, and it cuts out that cultural brokerage that now is being seen as so essential for helping keep the patient safe. So I would say, in the same way that the hospital guide for this module goes to senior leadership within a hospital or a healthcare system, there are elements in that hospital guide that could go to the leadership of organizations that train interpreters to help them utilize, have them review this module, and particularly the hospital guide with all of the evidence base that goes into it. And that's a way of reaching them with some information that has a solid research base that they can look at and see maybe we need to change the way we're approaching things. Otherwise, you do have a fine line, and you have to work that out locally. We certainly wouldn't advocate that an interpreter put their job on the line. At the same time, sometimes hospital staff have that same issue of putting your job on the line. If you're in a culture where it's not safe to speak up and you need to speak up for the safety of that patient, that's a tough call for folks all the time. And that's why this is an issue that has to be approached both frontline, speaking up, doing what you can, and senior leaders being presented with information that can help them make better decisions about how to approach these things systematically.
Okay, and we will try to squeeze in one, possibly two more questions, Laura, and then we will wrap up as I see we're nearing the top of the hour. So the next question is, this approach works well with staff interpreters. Do we include interpreters who are freelancers or agency interpreters working by video or telephone?
Yes, and a lot of hospitals use telephonic or video interpreters, and I would be interested in how you might utilize this type of a module and this type of approach with those folks, because I'm assuming that when you contract with them, there are some expectations of this is what we expect of interpreters in our hospital, in our healthcare system. These concepts of patient safety can be embedded into those expectations, even if you're working with telephonic interpreters.
Great. And the final question, I think I realize there are more questions, and I appreciate also the exchange of information that people are sharing with each other online. And I think this is an interesting one. Does this module work as well in an outpatient local health department setting?
It certainly could if you customize the examples. The video that goes with the module is of a patient coming into the emergency department. So while that's not exactly analogous to an outpatient setting, you can still utilize it in the same way for the skills that are covered in it. But the examples that you would use throughout the training, you'd want to customize them to reflect your setting where you're working. But yes, the same skills and approaches would be very applicable there. You might want to also review the TeamSTEPPS module that is out there for outpatient practices, physician practices. It has some examples and scenarios from that. You could sort of merge the two modules in a way that might work really well for you.
Okay. All right. Well, I'm going to stop there just because we have a couple minutes left, and I see we do have other questions, and I appreciate all of your participation. Again, we will get answers to any remaining unanswered questions and post them on the TeamSTEPPS portal. If you're not registered on the TeamSTEPPS portal, and I believe you can find it by searching that name, please do. It's free and open to anybody who would like to join our group. And, of course, you also have the information here as to how to contact HRET if you need assistance. So in closing, we want to thank all of you who have joined us today. We do these monthly webinars on approximately the same time each month on various topics that we think are of interest to the TeamSTEPPS user community. These topical webinars are scheduled and will continue through September 2014 of next year. Also, if you're registered on the TeamSTEPPS portal, you'll be able to track other exciting events as we launch them, including the annual conference, which is usually held in June, and often, as in last year, we will be looking for posters and papers and presenters as we move forward with that activity. So again, thank you all for your participation. Thank you for taking some time out today. I hope you found it valuable. And if you have any questions, please contact us either at the earlier number that I posted or at this email address, and we'll be sure to get back to you. Once again, thank you to you, Laura. Thank you to the support on the IMPACT and HRET end, and thank you to the conference service for hosting the call. And this concludes the webinar for today.
Ladies and gentlemen, that concludes today's presentation. You may disconnect your phone lines and log off your webinars and have a wonderful